I'm happy to call Mr. Arjun Takhar, who is a surgeon at the University Hospital of Southampton, and will give us his thoughts on 3D surgery planning. Thank you.
Okay, thank you very much, everybody, and I'm very happy to be here, and thank you for the invite. I'm an HPV surgeon in Southampton, and I'm going to talk to you about 3D modeling in liver surgery, specifically for hilar cholangio, as opposed to simply cholangiocarcinoma. No disclosures. So the case for doing an operation on these patients, we've had lots of talks this morning. We've got really good guidelines which show good evidence that if you can completely take these tumors out, you can get good 5-year survival. And although there's very good molecular profiling and targeting now, we know that an operation is still possibly the best chance of giving the patient longer-term survival. And these are supposedly the most challenging operations that you can do on the liver, and initial outcomes were quite poor, but we know that as we've gotten better at operating on this disease, the radicality of what we do, extended hepatectomies, etc., vein resections, the operative complications and mortality and morbidity have decreased. So there really is a very good case for doing these operations. But the problem, and I think most people who are sort of surgeons in this group will agree with me, that assessment of resectability remains the weak point here. We spend quite a lot of time working out whether the actual tumor is resectable, and there's lots of factors that go into it, not least the patient factors. You have to be really quite fit to have these operations, but also extent of tumors, where they are first, second order bile ducts, actual vascular involvement, vein or sort of arterial, obviously presence of metastatic disease. And these patients go through quite a long process before they are ready to have an operation. Mostly they are getting biliary drainage, and I certainly don't operate on anyone with a hilar or a perihilar cholangio without their liver being in decent health. And that means they really need to have good biliary drainage. But there remain a subsection of patients who the conversation you have in the clinic, quite a detailed conversation that goes through risks and benefits, talks about the fact that we think this is resectable, and we are going to explore with a view to a resection. And I think most people doing hilar type of operations will probably have had that conversation with their patients. So it was good to see that the guidelines do match up with what we do in Southampton. Don't really need to go through these in sort of detail, but 1 or 2 points are worth mentioning. As a unit, we do PTC, but of course, like most other sort of centers, we go out and do sort of outreach clinics and are still presented with patients by the local hospitals where it's quite clearly a hilar cholangio, but the patient has had an ERCP and the subsequent issues that come with it, mainly the bile duct inflammation, which then makes assessment of operability quite difficult. And as with most other centers, we sort of routinely do a staging laparoscopy to rule out sort of occult disease. Quite a lot of these patients will need to have their future liver remnant grown in size, so we now, as routine, do sort of double vein embolization. And of course, you go on and do a repeat assessment, make sure they're still operable, you've got a good FLR size, and the bilirubin has come down adequately for you to sort of proceed with the operation. And that's just a gratuitous slide just showing a sort of volumetric analysis, but also the end result of a vein embolization. So one of the things that you keep thinking about, and I certainly think about this a lot, that I end up doing an irreversible step. So whilst doing operations in general and complex hilar operations, the concern is that you've made an irreversible step. You can't turn back, but you've actually then discovered that the patient is inoperable. And it's not really happened that much, but this was a case that effectively prompted us to start thinking about different modalities of making an assessment of the tumor. So this was a 68-year-old lady, so this is 2 years ago approximately, very, very fit, walked her dogs 5 to 6 miles most days, had left side dominant disease, which is sort of seen over there. It's really hard to show hilar strictures on CT scans and snapshots, but left side dominant disease. We had drained her right dorsal, so right posterior sector there, so that was the main PTC. And the plan was to do an extended left hepatectomy. So for those who don't know, around 60 to sort of 70% of their liver volume leaving behind the right posterior sector with a biliary reconstruction procedure at the end. We in Southampton do these as a two-consultant procedure, and that's mainly not from a technical aspect, it's really to help with decision making. And both of us are doing this case. We, in our own assessment, have thought long and hard about the scans, been through them with our sort of radiology team, discussed at the MDT multiple times, think that we could proceed, transect the CBD. So we're literally there. We are exploring the patient as we speak, and find that behind the CBD, where the right hepatic artery runs, there's actually a tongue of tumor that is encasing the artery. And that is effectively telling you that this patient is inoperable and was inoperable before you started, except our own assessment, including that assessment at the time of the operation, was incorrect. We then had to do a salvage hepatocogenostomy, so basically joining up the bile ducts to a bit of bowel in an obstructed system, and to get one of our intervention radiologists to come in and replace the PTC. And thankfully, the patient didn't do too badly. She did have a leak, which settled down, but she was able to, 6 weeks later, go off and have palliative chemotherapy, and lived for about a year after that procedure with a number of treatments. So how do you stop that? And that's what we were thinking about. And I have to say, I've been doing this as a consultant for about 10 years, and that was probably one of the first times that we were faced with a situation that we really had got the assessment of the tumor, including in person, wrong. So we tried to think of ways and means that we could make better assessments of the scans, and actually I do a bit of pediatric surgery with our colleagues, and we did a case that involved a cable tumor where one of the cardiac surgeons who does pediatric cardiac surgery was there, and he was telling me about the fact that he used 3D printed models to basically make sort of bespoke models for each one of his neonatal patients to allow him to practice doing the operations on them, but also to work out anatomy in a very complex sphere. And so based on that, I, along with a colleague, contacted this company, Axial 3D, who are based in Belfast, and their specialty is that they convert the data files that you can obtain from CT and MRI into 3D models. So I've said 2020 there, that's meant to be 2022. So how they do it, so we had this sort of set up already because of the pediatric guys. You upload your file data from your scans onto their cloud-based server. They have a sort of AI-driven algorithm then that sort of basically segments, looks at the different aspects of the liver, and as you would know, you have the sort of bile ducts going into the liver, but you also have blood vessels, so the hepatic artery and the portal vein, and the segmentation literally divides that information into those different structures, which then we sit down with their technicians to make sure that there's good quality control, and then a 3D printer prints out the model. So here's an example of the segmentation, and this is happening in real time there, but we are also sitting down and pointing out, because their techs aren't medical, they have done quite a lot of this, but that's showing you the bile ducts there, here's the portal vein, and I think there was a little bit of a red thing showing you the hepatic artery. And you start ending up with an image model that looks a bit like that. That is then printed using a 3D printer, which will give you a 3D model, as you would expect, and you end up with something that looks like this. So the greens are the bile ducts. You got, in fact, here you've got a internal, external drain running across both sides here, with the drain coming out at the ampulla there. You've got the portal vein, and you've got the arterial structures. So you get a 3D representation on a scale model, but also a 3D visualization where you can literally turn the model up and down in quite a few ways. So going back to the inoperable patient, so we asked them to make us a model for that particular patient to see whether if we had printed this out, would it have made a difference to our decision making? And if you see, although the scans were basically telling us that this was potentially operable, there's a PTC, as you saw on the scan up on the right side. The actual stricture is sort of sitting here, and the hepatic artery basically disappears, basically telling you that that is enveloped by tumor. So I think if I had known this beforehand, we would have thought of saying to the patient that they were likely that they were inoperable. So potentially a change in decision making. So we then looked into see whether this had been done quite commonly, and actually there's very little published. There are a couple of groups in Australia and one group in Poland, and then some Chinese centers that have been doing a bit of work. But actually we found it very hard to get our own hospital to pay for the models. So as usual, we're here at a conference organized by a charity. We have a very active charity in Southampton. They're called Planets, Pancreas, Liver, and Neuroendocrine Tumors. And we made a submission for a grant to try and do 10 cases for a proof of concept study. And we did get £10,000 from them, which is what we are using right now. And the whole point of this is to see whether our actual decision-making at the time of operation or pre-operatively is influenced by using these models. And of course, you need to do better studies, but really it's worthwhile seeing whether this is worth doing or not. So a recent case from about 3 weeks ago, a 55-year-old female, really quite fit otherwise, sort of well-controlled hypertension, left-sided PTC with good biliary drainage. She really had bilirubin that came down to normal within about 3 weeks, which is good sign. Right side dominant disease, had a double vein embolization to grow her future liver remnant, but we had a concern regarding soft tissue on the right side of the main portal vein. Sort of at Southampton, we're quite happy to do wedge resections while doing hyalocholangiocarcinoma surgery, but we don't do end-to-end anastomosis. And mainly, this is because I think it's really quite a difficult operation anyway, and I don't think you help the patient very much by sort of giving them a massive clamp time on the vein, plus the procoagulopathy that happens whilst they have a cancer, an inflammatory state, and an operation happening at the same time. So tend not to, but wedge resections are fair game. So this was the plan. And scans, that's sort of where, again, hard to show on just a series of snapshots. So that's pre-op, where you can see the biliary dilatation. Hopefully you'll see the left-sided PTC, and this is post-DVE. The model, however, was telling us that the tumor had really a very large contact point behind the portal vein. The plan was that we would do an extended right, and actually you can see that the left hepatic artery runs off quite early, so quite happy to take that. But actually, real concerns here, so this was the 3D model, that the vein had quite a lot of contact. And sure enough, that was the case. But it did require quite a lot of optimization with the techs to show them the bits that we were quite concerned about in terms of the soft tissue. Also, we found it very useful in training. So we do a lot of laparoscopic, so keyhole surgery in Southampton on the liver, and in lap surgery, the posterior lesions, so this is the cancers that, or growths that happen at the back of the liver, are quite hard to get to, but also when you have trainees who've just started out, they find hard to sort of visualize where to find these tumors. And actually, having a 3D model sitting with where the tumor is meant to be on the liver has proved extremely helpful, because you can not only show it on the screen, but you've got it sitting next to you to help them work out where they should be putting their scanning probe to work out where the tumor is. And this is a small intrahepatic cholangiocarcinoma that was resected laparoscopically. So at the moment, we're on to, so we don't have much money, as you can see, so we have reserved this for the hyalocholangio. So we've done 3 so far, 1 quite easily resectable, 2 that were not. There is a question in our unit that is the 3D visualization on the 2D screen just as good as the 3D printed model? And we do think that this has worked extremely well in the training aspect. But as usual with everything in the NHS, there are cost constraints. Happy to take questions. I'd like to thank Planets and Axel 3D. Thank you.